we invited you on our show today because, you had told me a couple of years ago that you had been very fortunate enough to get some research funding, some grant funding, to do scholarship about race, medical statistics, medical data, and healthcare. And that, I was very excited about your fellowship. And the subject of our show tonight, as we've entitled Racecraft and Medical Statistics. Now, some of our audience may not be familiar with Barbara and Karen Field's book Racecraft, which I have here in my stacks, but I'm not going to reach out to. But as I know you are familiar, because the Field sisters are definitely within the Reed tradition. Can you explain for our audience what exactly do we mean? Because I know what we mean. When we say racecraft in medical statistics, what exactly is that suggesting or intimating?
Yeah, it's suggesting this. So, I think the idea behind racecraft, like the idea behind witchcraft, is not to say that the phenomenon's not real, but it is kind of collectively imagined, right? It's collectively imagined in a way that it can have an impact on reality, even though it's not really capturing anything in the way of a meaningful distinction. So I think a problem with the way that data is reported in terms of racial, ethnic, or let's say indigenous status is if you don't properly contextualize what you set out to reveal in the data, it can lead to very unfortunate and problematic interpretations of the data that you're viewing that might suggest that, say, in the area of health disparities or health inequalities, instead of seeing the disparity or the inequality as the result of social, economic, political processes, they get interpreted as the result of attributes, genetic, biologically determined attributes of the population in question. And I think that that's a major problem in the way health statistics around race, ethnicity, and these sorts of categories. That's a problem with that you see today, where there's not enough context behind the data that we're looking at, and that has the tendency of reproducing the idea that what we call race or what we call ethnicity are real, meaningful kind of genetic distinctions among populations.
So Dean, can I trouble you to possibly give our audience an example of what you would call racecraft in terms of medical statistical analysis? Is that something that you'd be willing to do for us?
Well, I mean, I could hazard that by saying that over the course of the pandemic, it was well documented, it was well discussed that uh, racial and ethnic, populations had a much higher mortality, than the general population. If you look at death rates, if you look at, risk based on pre-existing conditions, we heard a lot about that. But when you merely recite those statistics, it can lead to the interpretation that, well, maybe there's something about those populations, something in their kind of genetic predisposition that might uh, increase risk of illness and death, rather than understanding uh, rather than understanding any kind of health outcome as the result of economic and political processes. And that's the point that I'd really emphasize, that in the end, the health outcomes really of any racial, ethnic, indigenous category, including whites in America, these statistics are reflections of political economy. They're reflections of political and economic processes and inequality, not some inherent, again, discrete uh, genetic differences, among the populations that we look at.
So you mean to tell me that when we hear things like 35% of black children or black men under within the category of living in X area are 65% more likely to have diabetes than white men who are 35% of this category who live in this area. There's a problem with framing those statistics in that way without greater context.
Yeah, absolutely. I mean, I think that the audience is familiar with this idea of intersectional analysis, right? That you're supposed to, look at multiple factors in explaining an outcome. And if we take intersectional theory with any degree of seriousness, you'd want to factor in class or position in a capitalistic economic hierarchy as one of the fundamental determinants, as well as other ascriptive categories like race, ethnicity, indigenous status. So, to say that more simply, um, class is the most powerful predictor of illness and death, morbidity and mortality. So that among blacks in the United States, you see a class gradient where the poor have higher death rates than the middle class. Middle class has higher death rates than the affluent, and that's just among black people in the United States. So there's what we call a class gradient within each population, and then you'd look at disadvantages that are compounded by institutional racism and that sort of thing. But unfortunately, I'd say that when you simply report about elevated rates of diabetes among black people or various populations indigenous, and you don't contextualize that within uh, um, social status as a function of class, you're really missing a very important dimension of the way disease and death is distributed, within a population.
What about the argument that there is so much implicit bias within the healthcare world that it kind of permeates even the class discussion? Part of that clip that I was trying to play show that there was quite a bit of research done that regardless of where you were in class, you still were going to have a harder time uh, with going to the doctor.
Yeah. So there is evidence of implicit bias even when you control for things like the type of insurance you have, your age, your sex, uh, the conditions that you present with. There is evidence, right, of unequal treatment in the clinical setting. There's no question about that. But it's important to note that you know that is not inevitable. That basically equitable access to appropriate care has often been shown to eliminate those disparities that you see. So for example, for example, we know that that black men in the United States have the highest prostate cancer mortality, among all populations. But we also know that in the right healthcare system, right, systems that are less fragmented and less commodified, where quality of care is emphasized, you don't really see the manifestation of that kind of racial disparity.
So like the
So
VA.
yeah. So there is evidence of implicit bias. I think it's exacerbated in a very fragmented, more commodified kind of healthcare system. But there's also ways that we could address that, and that's one of the reasons that we need to get behind the idea of an improved Medicare for all,
Mhm.
because that's one of the ways that you provide not only a kind of universal basis of funding, but that funding then becomes a mechanism through which you can enforce compliance and make sure that whether it's gender, whether it's race, whether it's indigenous status, that patients are receiving, appropriate and quality care in that clinical encounter.
So you're seeing it more as health being, or healthcare being a commodity, kind of forces a eugenic thought in the price breakdown and
Yeah, well, I
treatment
guess
and
I'd
quality of
say
care.
this, that, I'd say it this way, that you kind of mobilize stereotype under certain conditions. And, we all know that, what the practice of medicine is like right now. You often don't have consistency in terms of your primary care. The examinations tend to be rushed. Insurance companies mediate. It's a very fragmented system, very high pressure system. And under those conditions, that's when people tend to mobilize these kind of stereotypes and implicit biases, so to where, there was a study in the Journal of the American Medical Association Pediatrics, I think it was 2015, that showed that, children presenting in emergency room settings, all things being equal, Black children were less likely to be prescribed pain meds, even though they're presenting for appendicitis, right? So again, under certain types of clinical encounters, it's plausible, right, that these stereotypes and these biases can be there. And by contrast, when, given the right system, given the right approach to quality of care, you don't find that those disparities are materialize in quite the same way.
Thank you for watching. Please don't forget to hit like and subscribe on your way out. You can catch the live stream of This is Revolution every Tuesday through Thursday at 6 p.m. Pacific Time and Saturday, 9 a.m. Pacific Time. This is Revolution.